Hey everybody, welcome to another episode of Rainer's Peer2Peer, the podcast. My name is Paul Singh. I'm an anterior segment and glaucoma surgeon out in southeastern Wisconsin at the Eye Centers of Racine and Kenosha. And we're here to talk about Omidria, the first and only NSAID, intracameral NSAID approved by the FDA. And I'm here with my really good friend, Kendall Donaldson from Miami at Bascom Palmer.
Paul, it's a privilege to be here with you. We're at the AECOS meeting here in Deer Valley and sitting out in the backyard chatting, so thank you for including me. I work at the Bascom Palmer Eye Institute in Miami and Plantation, Florida, where we see, it's a hospital-based setting, so we work with the residents and the fellows, and I do cornea, anterior segment cataract, and refractive surgery there.
Yeah, always learn so much from Kendall. Some really good cases here too as well.
Same. Always learn from you. Yeah.
But what is so much fun today is we can talk about something we use a lot actually, which is Omidria, which is phenylephrine and ketorolac, which is an infusion in our irrigation solution during our cataract surgeries as well. And it's been around for a few years now. It's not that new anymore, but right. I still think maybe some people don't realize some of the benefits clinically and even in office and efficiency. So let's talk about kind of what it is and why we use in our practices during cataract surgery, Omidria.
Sure. There's so many benefits to using Omidria in our irrigating solution. First of all, I did mention that we work with residents and fellows. And so just increasing the pupil size during our cataract surgery is so key because it increases our field of view during cataract surgery, which makes the cataract surgery safer, easier, faster, which ultimately can help patients recover faster and easier, and it helps patients be more comfortable. So we want our patients to have the best experience possible during cataract surgery, and it can also reduce the risk of postoperative issues such as inflammation, whether that be intraocular inflammation like CME. There's lots of good data that show that there's a decreased risk of CME and intraocular inflammation following cataract surgery. So it's really been great for so many different reasons.
I totally agree. Now, as a glaucoma specialist, I see a lot of people with pseudo exfoliation or even smaller pupils from hyperopic eyes and people with LPIs. And, it's not just about the dilation, but maintaining that pupil size, right, during the surgery. And, I've even noticed when you do iris hooks or even touch the pupil in any way or touch the iris, all of a sudden that eye is just not the same eye anymore. And I think when I use Omidria, you can see with that phenylephrine in the bottle, and ketorolac, of course, it really does maintain that tone. And so that tone is so important. Things like iris prolapse during Flomax patients or hyperopic eyes. So it really has help from an efficiency perspective. But I think you're right. Safety and not touching the iris, less inflammation. And I think having ketorolac in the bottle, we'll talk about later on dropless, but having ketorolac infused throughout the entire case, I really do think helps suppress that inflammatory cascade from even getting started. A good friend of mine, Brian Schaefer, will talk about the study we were part of. He's always talked about stopping that fire before it even starts. It doesn't let it get smoldering.
Exactly.
And that's because once you stop that blood aqueous barrier from getting opened up, you tend to have less inflammation after surgery. Talk about your experience with that. You talk about pain and inflammation.
Absolutely. So we see so many different types of challenging patients, and you mentioned just a couple, like the Flomax patients, the diabetics. A lot of times they don't dilate as well. We do a lot of post-vitrectomy cases as well. And so all of those patients have limited degrees of dilation. It just makes the case so much easier and faster. And if the case is faster, there's less fluid going through the eye. We end up using less energy during phacoemulsification. So it just makes the whole process easier. And of course, the faster we get in and out of that eye, the faster the patient can recover after surgery. And now we spend so much time talking about the patient experience, trying to give our patients a real premium experience in many cases. All these premium cases that we do, we want to be able to offer that premium technology to more of even these challenging cases. And Omidria really gives us the opportunity to do that by making these potentially challenging cases a little bit easier.
Yeah, and I think you mentioned too the experience after surgery, and a part of that's even immediately post-op day one, or even same day. There's been studies with Omidria showing less pain after surgery, less use of narcotics and other medications that we have to use to help suppress pain. And I think that helps from a cost, but also you're right, a patient experience, recovery time, and all that really does is included in that overall journey for that patient.
Yeah, absolutely. We've really heightened those patient expectations. And a lot of times now we do post-op day 0 visits. So we're seeing patients maybe in the afternoon of the day of surgery, and they're really expecting that they're 20/20 pretty much immediately after surgery. So, this really helps with that whole meeting expectations in these patients, whether they're premium or not. But, we really should try to elevate ourselves to that degree of, follow-up with our patients and giving them that great experience after cataract surgery.
Absolutely. And I think you mentioned also this journey, and I think it is a journey. I think we're getting judged now, but from our patients, even from Medicare and other governing bodies, of how happy our patients are, patient satisfaction. And when you look at the journey of the patient, it starts not just at the time of surgery, it's pre-op, and all the visits they have and the measurements that we have to do for them, and then after surgery, their experience. So talk about just the time and effort it takes when we have to use topical drops, because I know we're going to talk about dropless in general, but just in general, before we start there, how much of a pain is it to deal with topical medications pre-op and even post-op?
Paul, it is such a pain, as you know, on several levels. I mean, drops start being a pain even before surgery when we have to prescribe the drops. And really the standard of care has been 3 different drops, an antibiotic, a nonsteroidal, and a steroid drop. And for all these years, we've been doing 3 different drops. And now we're spending more time thinking about how to do less and less drops. So yes, prescribing the drops for us, as a provider or our staff members, and then getting callbacks from the pharmacy saying, oh, this drop is not covered, you have to change it to this. And so all the callbacks into the office. So it's also a pain for our staff.
Absolutely.
And not to mention the patients when they go in to the pharmacy and they find out this is not covered or this other one is covered. And a lot of times we have elderly patients that can't administer the drops themselves. And so they need someone to help them post-operatively with the drops.
Yeah.
So that can be really a challenge for some patients. And some of our patients have eye phobia. And so it's hard for them not only to have the surgery, but also to handle the drops and, put them in their eyes. And our patients have other diseases like, rheumatoid or things like that make it very difficult to handle the drops, especially in our older patients. So it can be a challenge for, us staff, the physicians and the patients. And the family members for that matter.
Yeah. And if you think about how precise we like to be in surgery, whether it's making sure our astigmatic corrections perfectly on target or the right biometry, we look at topographies, we're trying so hard. And then when it comes to the post-op period, we're like, whatever you want to use, we'll see what happens. And I've had a lot of patients where I didn't realize they didn't get the drops I prescribed, or they didn't even get them at all. They got, there's a lot of disconnect between what we think is happening, what's really happening. And talk about, just your experience. And I know you're doing a study, right? I think on just the overall efficiency and flow and the impact it has on staff and patients taking drops and prescribing drops. Talk about your study at Bascom.
Yeah, so we're looking at the burden of eye drops on the post-operative experience. So we have several components to this study. The primary component is just getting feedback from patients. So we have a survey that we give to patients at post-op month 1 after their cataract surgery, just to find out a little bit more about if they got their drops in, if they honestly got their drops in, if they did what we asked them to do, if they were able to do that independently or they needed help from someone else, how many phone calls did they have to make either to our office or to their insurance provider or to their pharmacy to make sure that they got what we prescribed, and just sometimes calling in to clarify. So that's one part of the study, just looking at the patient experience a little bit more carefully. Because a lot of times we might not even know, some of these things until we ask specifically. Then the other component of this study is looking at the burden on the office. And so we have essentially, we're logging in every call and everything that comes through our electronic medical record related to the drops post-operatively, any challenges or clarifications that need to be made. And we're looking at the number of calls, the amount of time that's taking from both staff members, and I have 3 cataract surgeons, including myself, that are taking part in this. So we're working on compiling that data, and then we're going to extrapolate to a year to just kind of figure out what is the true burden on all levels of the process here.
I love it. I love it. We did a study many years ago, not probably smaller scale than what you're saying, but what we found is when we got rid of a topical medication, we found this in the glaucoma world and in the cataract surgery world. When you got rid of one medication, we saved an average of 5 minutes per patient per visit. And it had to do with, to your point, all the callbacks, verification, are you on the right medications? Do you need refills? Which eye, et cetera? And all that takes time and effort as well for the staff and the FTEs. So I think it's great that you're doing that so we have more data. And I know Lisa Nijam recently did a study too as well showing us same idea that I think 7 minutes of time saving. So I think we're seeing multiple data sets out there, and I think yours is going to be really, I think, robust at a hospital, large center, to show us that yes, this really is impactful for the efficiency and flow. And I think as we see more people coming through our doors, we're seeing a lot more in volume of patients coming through where we have to service them the right way and do the best job we can for these patients, but yet time and it's hard to find great people. So being able to reduce the drop burn, I think, is going to help everybody.
Yeah. Again, I mean, the main goal is to elevate the patient experience.
Exactly.
But Omidria doesn't just help with elevating the patient experience as far as just the annoyance and burden of drops, but it really does help them clinically.
Yeah.
You know, we had commented before about decreased inflammation and potentially faster healing and better vision faster, you know, and just having a more comfortable experience. You know, you had mentioned the narcotic usage you know, during a cataract surgery through the anesthesiologist, and trying to get away from narcotics, the IV. You know, we're moving. I know you have a,
OBS,
in office
5
surgery
milligrams of Valium.
center.
That's all we use now, and that's it. I think using less narcotics, intra-op and post-op, you get patients who I think are more cooperative. Like sometimes they get disinhibited when you use a Versed or fentanyl or something else, and then after surgery as well. Versus when you do something like an oral Valium, they tend to be relaxed, but they're still more cooperative, and you can converse with them. And so I think for me, that's been a really big, new change in our practice pattern as well. But using Omidria, having that calm and anti-inflammatory, and that pupil stability, I think has aided in that whole comfort level of using just oral Valium as well.
Because I work in a hospital setting, I mean, we still have to use the IVs, but I do kind of envy you since you have your in-office suite. But, you know, that's the direction that we're moving in. And even hospitals, I think 10 years from now, we'll be doing in-office surgery, and we won't have the IV, we won't have the anesthesia team. So having, you know, the Omidria in the bottle to help patients be more comfortable to kind of get us away from needing some of those stronger medications will be really helpful. So, you know, I think it's a component of what we'll be doing in the future. So,
absolutely. And, you know, we mentioned, you know, dropless. We're going to get to kind of this whole idea of not using drops at all. But before we get there, do we need the NSAID and the steroid? You know, and talk about any data that you know of or anything out there that shows us that, hey, you know, it's probably a good idea to use the NSAID and the steroid.
Correct. Yeah, no, there's definitely good studies that show that we need to use both the combination of an NSAID as well as a steroid together, really help decrease the inflammation and help the healing process occur more readily, you know, post-operatively. So again, that just helps patients heal better and improves the experience post-operatively for patients. But we really do need both, and so we have good studies to support that.
Yeah, and that was something that I had to like look at too as myself, because there was a time I was like, well, maybe I just need to use the steroid, or do I even need the steroid? Just use the NSAID alone. And if you look at the data, like you were mentioning, if you look at kind of inflammation and even rates of inflammation like long term, it is better when you use both the steroid and NSAID as well. Which gets me to the point of, how do we get to dropless? I mean, we've talked about dropless cataract surgery for years, and there's been different iterations of how we do it. But talk to me about kind of how you guys are thinking about dropless, and where does Omidria fit in that? What type of steroid? And let's kind of go through all that and how to implement.
Well, I think we have so many different options these days, and just moving in that direction step by step. I mean, Omidria is the only non-steroidal that's available in something other than a drop form, but we do have several options as far as steroid administration. So we have Dextenza now, or we can do a subtenon's, you know, Kendall. So there are different ways that we can administer the steroid. You know, some people are moving toward dropless by using combo drops. You know, I've used Imprimis to do a triple, you know, combo drop that has the non-steroidal, the steroid, as well as the antibiotic in there. But that's still a drop, but it's one step in that direction.
Closer to less topical medications, less number of bottles and number of drops, because it gets confusing for, I'm not sure if you have patients coming in who are like with a sheet of paper that they're like, you know, those people who are really particular, and they have the color-coded sheet, and they're like, well, I'm on this side, I'm on twice a day, but this I'm on 4 times, and you're like, oh my God.
Complex spreadsheets,
it's like,
you know, that are
cow.
color-coded.
And you're like, I don't know how you do it. It's like, there's no way I would do that. But
but I almost feel guilty that that's what I made them resort to organize their life for this month after surgery. And usually, you know, it's their child or their one of their family members that has created this thing for the refrigerator.
Yeah, it's
And they're so
amazing.
proud of it.
I know they try so hard. I'm like, I
Yeah.
feel bad, but thank
Yeah.
you. It's,
Yeah.
it's for you. But yeah, we've been involved with dropless kind of different ways. And yes, we use a lot of intracanalicular dexamethasone or Dextenza as well as a steroid. Recently, we were part of a study that myself, Kathy McCabe, and Brian Schaefer, we presented our data at ASCRS, and we should be publishing this paper soon, looking at comparing topical medications, so the steroid prednisone acetate, moxifloxacin topically, as well as ketorolac, and then using that versus in the patient's same eye, we randomized it to one eye with the drops and one eye with Omidria, a subconjunctival, not subtenous necessarily, but a subconj triamcinolone, and then intracameral moxi. So one eye with drops, one eye with this dropless, and then we randomized which eye was first, et cetera. And what we found was actually non-inferiority. At the end of the day, we looked at inflammation at day 8, we looked at inflammation at day 30, we looked at macular thickness and CME rates, we looked at patient satisfaction scores, and what we found was non-inferiority to topical medications. And that was really important for me because I always wanted to do dropless, but there's always a part of me that felt, is it going to be as good? We didn't want to be superior from an inflammation. I wanted to be as good. But we found that we were as good, number one. Number two, we found patience. By far, we did a VAS, a visual analog scale, asking which eye did you prefer better, and it was by far 90+% said, "Oh my God, this eye, the one with dropless." Like, why? They actually got mad at us. In fact, we asked them to write down what their feelings were, and in the drop arm, we heard drops suck.
Yeah.
We hate drops, But it was amazing of how much more happy these patients were on the dropless eye, and just it was a verification for us.
There's no patient that would choose to do drops if they had an alternative, honestly, So, no one really enjoys doing drops, doing anything 4 times a day, which is what we would typically do with the drops. So it's hard to remember to do something 4 times a day.
It is, and then the topical, surface of the eye and the confusion and the cost. We found the cost was actually less costly to the patient out of pocket when you were in the dropless versus having the topical medication. Even with generic prednisolone and ketorolac, it was still more expensive in that arm than the dropless arm as well.
Well, and one other issue is all the toxicities that we can see with all these drops that we're putting on the surface. A lot of our patients, and I know you do glaucoma, but a lot of my patients have glaucoma and they're on medical treatments. But, we're adding 3 more drops to potentially 3 other drops that they might be on for glaucoma. And especially, the non-steroidals can be really tough on the surface of the eye. So just adding all those extra preservatives. And, we're doing a better job at diagnosing neurotrophic keratitis. So, many of our patients have neurotrophic keratitis or medicamentosa or other issues.
Absolutely. So many of my patients on topical medications going into surgery, I probably don't diagnose enough of the neurotrophic patients because, and even after TRABs and how many patients have mitomycin, they've limbo stem cell deficiencies. There's all these things that we torch the eye with.
So I could tell you, I definitely have had some patients who were teetering on the edge before just routine cataract surgery, and then we add drops and certainly the topical NSAID, and then they start breaking down. So that kind of unmasks, it just pushes them right over the edge, so, and then it's tough to get them back. And then they're upset, and you think, gosh, I just did perfect cataract surgery, and now they're unhappy with me.
It's so frustrating.
So it can be very frustrating.
And so that's why those studies are so important. And in our study, we found that from a macular thickness or CME rates, we saw no statistically significant difference at 90 days of CME rates between the dropless arm and the dropped arm as well. So that was something I was also worried about too. If I don't have a topical medication, am I going to get higher risk of CME?
Right.
And we included patients who were diabetic. We included patients with ERM. We included denser cataracts, 3, 4+ NS cataracts, and we found no difference as well. So I thought that was really comforting for me. I really feel like I can go now to this dropless world with confidence.
Absolutely. I'm looking forward to your study because that's just more good information. Although there are some other studies out there that have shown, a lower rate of CME, so we can feel more comfortable with all those complex cases like you mentioned.
Well, and Eric Donafel has done a study with Dextenza and Omidria as well, showing the same thing with intracameral moxi and showing, again, non-inferiority to drop topical medication. So I think to your point earlier, whatever steroid you want to use, whether it's intracameral, canalicular, subconjunctival triamcinolone, having, I think, that intracanalicular, kind of at the time of surgery of ketorolac and phenylephrine really suppressing that inflammatory cascade, I think sets us up to allow us to not have to use as much steroid after surgery as well. And that's kind of the common thread, I think, with all these kind of dropless regimens, is having that intracameral, steroid, or NSAID rather.
Yeah, and as you mentioned before, we're spending a lot of time talking about dropless in different formats at all of the meetings now, trying to really preserve the surface and improve the patient experience. I'm hoping that we'll also get intracameral moxie or some other form of intracameral antibiotic eventually approved in the United States, so we can kind of get to the level of our European counterparts where they have that available as well. So that would move us in the right direction to head, make it easier for us to go completely dropless.
Have you used subcons or subtenons triamcinolone before?
I have.
Yeah. I think there's a fear factor there, but we found it was actually really simple for us to do it. I mean, talk about your experience with doing.
We do it often in the clinic as well for various, corneal transplant rejection. And also, that's something that we've used. But to use it routinely in the operating room, I haven't been using it routinely in the operating room. There's always that concern about the pressure increase with Kendall specifically. But I think with the Dextenza, which we're going to be starting to use, I think we'll be able to feel a little bit more secure about that. But lots of people are already using either the subtenons or subconch.
I'm glad you brought that up too, because we use 40 milligrams, and what we found was no difference also in IOP rise. That was something that we were too concerned about, is if we do the injection versus topical, and we found there's no IOP spike. Doesn't mean it's not going to happen, but we didn't find any difference.
Occasionally you can have, I'm sure, a glaucoma patient that you have to be a little
careful.
more cautious about that kind of situation.
Exactly, and you can always release it too if you had to. You can go open and release, but you're absolutely right. It's always important to recognize that. But in the study, we didn't find that out as well.
That's great to know. Yeah.
Any other thoughts on just your experience with Omidria and kind of where we're headed in cataract surgery in general?
Sure. Well, I'm pretty excited that the insurance coverage has gotten so much better for Omidria. We were using it maybe 4 years ago, and it was a little more challenging, but it's just gotten easier and easier for us to offer that to more patients. Because honestly, I would love to use it for every patient. And so, I'm excited that everyone's paying more attention to dropless, which has also allowed us to get the insurance coverage for patients. So, I think probably if we're sitting here talking about this 3 or 4 years from now, I think that if you're just using drops, people are going to look at us like we're behind the times, and why haven't we moved on to offer our patients this, improved experience?
Yeah, we actually, funny story, I was thinking about it as you were talking. We did another study many years ago. We asked patients at 90 days after surgery, those who were happy with their outcomes, what was the most difficult part of surgery? Drops. Number one. And then I have patients.
Surprised, yeah.
I have patients coming in now who are actually asking, like, Doc, do I have to take drops after surgery? How many drops? I heard my friend had to take 3 or 4 different medications. And so they're already thinking about that. That anxiety already starts even when they're coming in for the consult.
Well, I actually have had some patients come in and they're specifically looking for a dropless surgeon. So it actually can be a practice builder as well. So if the person down the street is using drops and you're not, the word actually gets out. And patients are pretty savvy these days. They're all on the computer, they're all looking at social media, and they're aware of dropless surgery. So I think it could be used as a practice builder, really, another differentiator to build a practice.
Absolutely, and to your point, HOPDs are covering it now for Medicare patients as well as ASCs. So I think access is something that I think is going to be a little bit less of an issue for some of those patients. There's some of those doctors who are in hospital settings as well as ASCs. So
absolutely,
awesome. Well,
we have exciting things.
We're loving it. All technology.
We're
always looking forward to something new and doing it better for our patients.
And honestly, it makes us look good too, that we can be able to deliver what the patients are looking for and really elevate that whole experience for them.
Absolutely. So, well, this was
pretty lucky.
Awesome hanging out with you in this beautiful setting here in Deer Valley. And
no, it's beautiful out here. So
love learning from you. Thank you for all you do, Kendall.
Absolutely, and same to you.
Appreciate that. And thank you, everybody, for hanging out with us in this another edition of Peer to Peer, the podcast. Take care. Thanks again.